Hello everyone. My name is Dr. Bilal Qaddoura. I'm one of the foundation doctors currently working in AAU. And today's grand round is basically going to be about a case that came in, and essentially the diagnosis was the meningoencephalocele. So just to give a bit of background, I do apologize for the formatting. It's gone completely awry. So if you can see and squint, you'll see that a meningoencephalocele, the first part to tackle is how to spell it, the second part how to say it. So that took quite a while. But essentially it's an abnormal sac containing fluid, brain tissue, and meninges. And it's essentially when it herniates through a defect in the skull. It's quite rare. It happens once every 5,000 live births. And the classification of meningoencephaloceles is based off the anatomical position. So, for example, a frontoethmoidal would be obviously located towards the frontal and ethmoidal bones, and the most common are the occipital. The cause of this generally is unknown. It's usually congenital, but it can develop by chance in older individuals. But obviously, this would be extremely rare. So it's thought that exposures during pregnancy to aflatoxins, toxins in the mold of nuts and seeds, legumes, and folate deficiency could potentially be contributing factors to the formation of a meningoencephalocele. But studies show essentially there's not enough evidence to fully confirm that. Associated symptoms include polydactyly with or without renal anomalies, Dandy-Walker or Chiari malformation, which I'll go over in the next slide, and chromosomal anomalies. You can also get hydrocephalus, eyeball, and tear duct abnormalities. So this is essentially what a Chiari malformation is. This is type 1, essentially where part of the cerebellum essentially goes down towards the spinal cord. And you'll see in Dandy-Walker syndrome, again, it's affecting this area of the brain, the cerebellum and the fourth ventricle. In Dandy-Walker, you can get cyst, you can get enlarged fourth ventricle, and abnormally formed cerebellum, and the brainstem may be compressed. Okay? So in terms of the prognosis of meningoencephaloceles, it's obviously dependent on size and location. If it's located more towards the face, they tend to have better survival rates compared with if they're more towards the back of the head. And it's also dependent on the content as well, and if there's any other abnormalities of the brain, including meningitis, seizures, things like that. 2/3 of those with occipital meningoencephalocele survive, and about 50% of those have normal intelligence. So in terms of survival rate, there's still a 30% mortality rate, which is obviously quite concerning. And then again, apologies for the formatting. In terms of symptoms, again, dependent on the location and size. If it's transethmoidal, they tend to get headaches, runny noses. If it's occipital, you tend to get swelling, which can even protrude in towards the eye, depending on how large the encephalocele is. And when that happens, it tends to be a blepharocele. And then obviously you can get it in the mastoid and middle ear areas, leading to otitis media, hearing loss, again, headaches and otorrhea. Essentially the workup, the diagnostic or gold standard, I guess, would be CT MRI, because it's very much a visual or physical kind of illness in the brain. And then in terms of treatment, you can do a conservative treatment, mainly treating symptoms, but the definitive would be neurosurgery via a craniotomy. There are studies trying to compare what types of craniotomy are preferred and which have better outcomes. But again, further studies are required essentially to properly narrow that down. So moving on to our case study then. In fact, before we do that, does anyone have any questions? I think I'll take that as a no. Yeah, okay. So in terms of the case study then, oh God. Squint even harder if you can. 33-year-old male with a past medical history of Arnold-Chiari malformation and hydrocephalus that was diagnosed in 2018, sleep apnea, and rhinorrhea for 7 to 8 years. Their social history shows they had no alcohol, no smoking, no recreational drugs, no exposures in terms of industrial at home, and they live with a partner and are fully independent. A frailty assessment showed them as a 2, so they were quite fit, and they have no significant family history. Their drug history includes levetiracetam 500 milligrams oral BD, and they've been found to be allergic to meropenem, which caused a drug-induced hepatitis. So I'll try and ask for some participation, just so it's actually two-way conversation. From the background currently, what risk factors are we thinking when it comes to meningoencephaloceles? Anyone? Anyone at all? Okay, so I guess the one that's sticking out the most would be the Arnold-Chiari malformation, because like I mentioned in the a couple of slides ago, that's one of the risk factors for it. The fact he's also on levetiracetam, anti-epileptic, again, we'll obviously go into the history a bit more as to why he's doing that, but it's likely due to seizures, possibly due to epilepsy. That would also be another kind of essentially a risk factor. But other than that, there's nothing else. It makes you wonder then in this patient, if there was a meningoencephalocele, is it a spontaneous one or was it from birth and just missed? But anyway, so going into the presentation. So he presented with a headache for 3 days, gradually getting worse, and at the highest, it was about a 10 out of 10. He describes it as like an elastic band around the head, and it was associated with nausea, vomiting, dizziness, and balance issues. He had no seizures, he had no incontinence, no visual problems, and no cough on this admission. He did have fevers and shortness of breath. So I want to try again and get some participation, please. What are we thinking at this point in the presentation? Okay, I guess I'll move on. So in terms of his recent admission and probably why he's on the levetiracetam, he had a recent admission with status epilepticus. Essentially, he had ongoing seizures, 4 seizures in total, and his lactate on admission was more than 20. He had a temperature spike of 38.8 degrees Celsius, and his heart rate was very high at 111. When he was admitted, he was given some diazepam and lorazepam, and he had to unfortunately be transferred to ITU for intubation for 2 days. He had rhinorrhea, essentially, that they tested for CSF, and they tested to confirm this by looking for the beta-2 transferrin to confirm it was CSF fluid. But essentially, they did this because they wanted to rule out if there's any meningitis. They couldn't do a lumbar puncture because it was contraindicated, most likely due to the Chiari malformation. They gave him a cyclovir and ceftriaxone, and then through the advice of microbiology following the CSF fluid sample that confirmed bacterial meningitis, they upgraded to meropenem. The problem is that almost immediately this kind of caused adverse reaction and drug-induced hepatitis in the patient. So they went back to ceftriaxone for 10 days. At the time of the previous admission, the neurosurgery team said that he's more for conservative management. So going on to the examination then. General appearance, he was not in pain, he was dehydrated, but clinically stable. His new score was just a 1 due to the temperature. His JVP was not visible, and heart sounds were present and normal. His chest sounded clear, his abdomen was soft and non-tender, and his legs were also soft and non-tender. Now, on cranial exam, cranial nerves were fine. His GCS was 15. He had no neck stiffness, and Koenig's sign was negative, and Brodzinski's sign was negative as well. There was no problems with his coordination, and his arms and legs had their power and sensation intact. So essentially, at this point, the differentials were mainly meningitis, to rule out meningitis again, due to a previous admission, CSF rhinorrhea, and encephalitis as well. When he was admitted, the investigations included a CT head, chest X-ray, ECGs, and bloods. They took some blood cultures, and they tried to get a CSF sample again, obviously through the nose, and a urine dip as well. In terms of his management, we continued with his IV ceftriaxone, gave him some antiemetics, and we monitored him for seizures. We then had to involve, and it really kind of highlighted the multidisciplinary team, but we involved the neuro team, ENT, and MaxFax for definitive management of this patient, because we were concerned that what we can do from the side on AAU is, yes, we can treat his meningitis or we can give him antibiotics, but if he has what we think is a possible connection between the nasal cavity and his brain, then he's just going to keep getting these infections, and it's not going to look good. So the results of this case study essentially is that his CSF fluid produced S. aureus capitis with no viral load, and this time there was a heavy growth of the S. aureus and coag-negative staphylococcus. His white cells in the CSF were 39 and were mainly lymphocytes. And his blood results also kind of showed a spike in white cells and CRP as well, but they were otherwise normal. A CT head showed a persisting ventricular megaly of the lateral and third ventricles, while the fourth remained normal, but he did have 3 encephalomeniнгioceles, the Chiari malformation, but no unchanged appearance compared with the previous imaging from his previous admission. And his chest X-ray was clear. So on the previous scans then, he had a CT and an MRI, which essentially showed those 3 separate encephalomeniнгioceles due to 3 separate osseous skull-based defects, one being in the right cribriform plate, one being in the posterior wall of the frontal sinus, and the third being the roof of the frontoethmoidal air cell. Okay? So for this patient, essentially the outcome was that we treated the meningitis. We got micro input just to confirm duration of antibiotics and any escalation plan, which was ceftriaxone and vancomycin. We also did a stool culture, and unfortunately he was C. diff positive, but toxin negative. So he was then transferred to a side room, and we continued the ceftriaxone. And neuro input said essentially continue with the antibiotics, and because of the frequency of admissions, he's likely for neurosurgical repair. They wanted us to increase the Keppra to 750 milligram twice a day, and then increase in a week to 1 gram twice a day. And fortunately, he became clinically stable and was discharged for review in SDEC. ENT input also said is likely for repair for the meningoencephalocele. So this was during February. So I think we're still, well, if you're interested, I was still waiting to hear back from them to see if there was any update in the documents, but there was none so far. And to just finalize the presentation, here are my references. Does anyone have any questions? I hear silence, so either no one's speaking or no one can hear me. Any questions at all? Even in the chat? Oh, right. Is there any reason the meningoencephalocele wasn't repaired for? I think before, it was essentially not clinically indicated. I think what they wanted to do was to preferably manage conservatively. And I think because he had the admission, so both admissions, the most recent one and the one before that were both in February, I think probably a week or two apart. So I think the frequency basically kind of made his case more indicated for actual definitive surgical repair rather than seeing if we can get away with just medical management. Did that answer your question? Okay, you're welcome. Any other questions? Okay, I would assume no one has any further questions. So I guess that kind of finishes the grand round or the presentation. I hope everyone enjoyed that. If you guys need slides, obviously just let me know and I can send the email. But yeah, I guess that's it.
Great. Thanks very much for your presentation.
No problem. Thank you. Bye-bye.